Good afternoon, everyone, and welcome to TxRx Community of Practice Echo. Please note that we are recording these sessions for later distribution. Anything listed in the chat does not appear in the recording. My name is Shreya Prasanna, and I will be facilitating today's session. A few quick announcements before we begin. Please enter your name, affiliation, and email into the chat, which can be accessed by clicking on the speech bubble icon on the navigation bar at the bottom of your window. This helps us with attendance for the session. If you are one of our BWell Texas providers, please make sure that you identify yourselves during this session. If you're joining via phone, please email your phone number and name to bwelltx@utisca.edu. Some housekeeping, please stay muted unless you're speaking. If you're joined by computer, your mute button is on the bottom left of your Zoom controls. If you're on the phone, just press *6 to mute and unmute. We encourage everyone to speak at these sessions, especially during the discussion portion. We want to hear from you from as many of you as possible. So please keep your comments brief to allow time for others to speak up. Or if you would prefer, you can use the chat feature to raise comments and questions. Please note that no predicted health information is allowed in either the chat or our discussions, and that includes name, addresses, photographs, or anything that can identify an individual. If you would like to show closed captioning for this session, please navigate at the bottom of your Zoom window and select the Show Captions option. You may need to click on More at the bottom right corner of your Zoom screen to find this menu. Towards the end of the session, the BWell Texas team will send out an evaluation survey. All participants filling out the survey will be automatically entered into a raffle for a $30 Walmart gift card. Our didactic today is on overcoming barriers to initiating relapse prevention with XR-Naltrexone and will be presented by Dr. Adam Bisaga. Following that, we will be discussing a case presented by Kenzie Potter. We will start with some introductions, followed by didactics, BWell program announcements, case presentation, and open discussion. Thank you all for joining us at today's Echo. We look forward to learning alongside all of you and encourage you all to share your questions, experiences, and insights in today's conversation. And with that, we will do some introductions. Dr. King.
Hello, everybody. I'm Van King. I'm the medical director of BWell Texas, a professor here at of psychiatry here at UT San Antonio. Welcome.
Thank you so much for joining us. Dr. Walker.
Good afternoon. Crystal Walker, doctorally trained PA, and I am the Director of Substance Use Disorders Clinical Services for My Health, My Resources of Tarrant County in Fort Worth, Texas.
Thank you so much for joining us. Dr. Bisaga.
Hi, everyone. Adam Bisaga. I'm speaking to you from New York. I'm a professor at Columbia University. And yeah, I'm very excited to be able to reach so far as to Texas. I never spoke here.
Thank you so much for joining us today. Kenzie Potter.
Hi, everyone. I'm Kenzie. I work with Adam at Columbia at the New York Psychiatric Institute, and I was the protocol director for the study CTN97 that informed our protocol for XR-Naltrexone.
Thank you so much for joining us today. Jasmine Vidal.
Hello, everyone. My name is Jasmine Vidal. I'm a CSTAC program coordinator. Thank you for joining us today.
Thank you all again for joining us. And with that, we will get started with our didactics. Dr. Bisaga, you can take it away whenever you're ready.
All right. So again, thank you for coming and joining us. I know it's the holiday season, but it's so great to see so many of you interested in that. And I'm wondering if I could have a show of hands of how many of you have actually worked with extended release naltrexone and had to figure out how to initiate this treatment. Yeah, few of you. Okay, so hopefully, you know, let me know if you would like to go into kind of details or just to make sure that we cover all the basics about this as a medication. My disclosure is that I have I've been funded to do research on this medication, and usually pharmaceutical companies provide medication as a part of this research. It's mostly NIH funded, but I also got a grant to do some of the research for XR-Naltrexone outside of that. And I would like to briefly tell you about why many people find it difficult to initiate treatment with extended-release naltrexone, how we have kind of overcome some of the challenges, and then we will give you a results of the study, which actually tested the procedure that we developed. So just as a brief reminder, we have 3 medications that are FDA approved. All of this medication are interacting with the mu-opioid receptors, either by directly stimulating it, like with methadone, partially stimulating it like buprenorphine, or completely blocking the receptor, as is the case with naltrexone. And naltrexone, as you know, converts someone who is using heroin every day and goes through the phases of either too much opioids or not enough opioids, from intoxication to withdrawal, and it kind of stabilizes the receptor at the kind of basic level, and it allows kind of for the system to kind of restabilize itself. And because it is a very effective antagonist, any opioids that will come from the outside wouldn't be able to have any effect. And because of that, many people find that the craving is relieved, that the physical dependence usually doesn't restart, and their affect and general well-being improves. One of the limitations to initiating treatment with naltrexone is that you need to be fully detoxified, right? So you need to come from some kind of level of physical dependence to no physical dependence, otherwise you would precipitate withdrawal. There are many concerns about this. Some providers have more concerns than others. Usually people worry about whether it's effective or equally effective to other medications, whether it's safe. And obviously there's always concern with safety because that's the only product on the market. It tends to be expensive. I would like to just address one of those challenges, which is how to initiate treatment. But I have provided in the references for this presentation a lot of studies that address effectiveness, safety, effect on mood and craving. So please review if you have questions about those, or if you have any specific questions, we can address those. So difficulty with initiating this medication is the major barrier, because if you read the package insert, it tells you that you first need to detox patients, which usually takes 5 to 7 days. Then you need to have this period of abstinence, about 7-10 days, and only then you can give injection, right? So it takes about 2 weeks in a traditional setting if you only look at the package insert to initiate medication. Many patients obviously cannot really wait that long. Patients are impulsive, they don't feel well, they change their mind, and many of them give up on this attempt. So we have, for many, many years, worked on alternative approaches that could shorten this period to something that will be much better in practice. And this is the study that we have done about 5 years ago, when we have actually tested this rapid protocol versus the standard protocol in outpatient setting. And we have indeed shown that significantly more people can initiate treatment with the rapid protocol. So the rapid protocol is basically based on the idea that we only give 1 dose of buprenorphine on day 1. And then after about a day of washout, we will very quickly initiate naltrexone. The key here is that the first few doses have to be very low, so you don't precipitate withdrawal. But once you prime the system with the very low doses, the system can tolerate the full therapeutic dose much, much easier. So if you didn't have the low doses for the day or 2, you would still precipitate withdrawal, right? So we give buprenorphine as soon as the withdrawal emerges. And we don't try to give too much buprenorphine, because then, of course, you'll have a problem during the transition. But we use adjunctive medications that we'll talk about this to alleviate any residual withdrawal, right? This protocol really relies on adjunctive medication. It's almost like the clonidine only kind of protocol that have been tested in the past. But we give very generous doses of those medications. We give it throughout the protocol, before buprenorphine, during buprenorphine, and for the remaining of the stay. We give it the scheduled doses, so the patient always have medications That way we can prevent the withdrawal rather than try to treat it. And we have found this combination of clonidine with clonazepam and ondansetron to be particularly effective. And we'll talk more about this later. Once we get to about day 2 or 3 during this process, we initiate naltrexone given oral doses, starting with about half or 1 milligram. Those are compounded by the pharmacy, very cheap, very widely available. And by doing that, we can then again prime the system, let the system reset itself. And once you reach 6 milligrams, it's safe to give therapeutic dose. So this is the protocol we've been working, variations of this for the past really 20 years, first introduced by my mentor, Dr. Hep Kleber in Yale in late 80s. And then we have been working on this for all this time. And again, this protocol can be modified depending on tolerability. So in this study that I'll tell you about, we tested the standard procedure, which is a week-long taper, week-long washout, and then injection of the naltrexone, versus this rapid procedure when we give on day 1, on average 6 milligrams of buprenorphine. We give only adjunctive medications on day 1 and throughout. And then starting day 3, we start oral naltrexone with half milligrams. We tolerate it, give another half, go to 1 milligram on next day, and go to 3 and 6. And the injection on day 4, 5, or 6, depending how patient tolerate. All this time, patients are very comfortable receiving all additional medications. And we, in this study, assessed whether patients who end up getting this procedure did any better than patients who end up getting this procedure on the primary outcome, which is receiving the injection. This was the study funded by NIDA, by the Clinical Trials Network, CTN 97. We called it SWIFT. Here is why. And we have set this study not only to look at the effectiveness, whether the standard is or the rapid is as good as standard, but also on the implementation. So we collected implementation outcome. And again, we studied barriers and facilitator, what makes some of the units easier to adopt this procedure and why it still is a challenge for other units. So this was a multi-site study. We had 6 sites spread around the country, including one in Texas, and I see representatives of the site on the call today. We have aimed to recruit 450 patients, and the study was a step-wedge design, which is that every 14 weeks, we randomize one of the sites to switch from standard to rapid. So we had everybody starting standard, and at some point they were switched to do the rapid, so we could compare before and after, and then we can compare all the people who got standard to people who got rapid. And again, the primary outcome was whether they got injection or not. And we also looked at how long it took to get injection, what was the craving, withdrawal, and were there any safety concerns about implementing those medications. So we ended up getting 415 patients, which was, I think we're quite pleased because we did it during the height of the pandemic, where some units were closed for some times, and obviously there were challenges with staff. But we were able to get a sufficient sample. On average, patients were 34 years old. Half of them were females, majority were white, and half that had health insurance, unhoused. About 1/3 of those did not have a stable housing. Most of them, well, actually half of them have been treated with medications before. Most of them had overdoses, on average 4. Most of them have been already in the inpatient detox setting at least 4 times. Interestingly, 63% of patients were positive for fentanyl, so they were using fentanyl as their preferred opioid of choice. Quarter was using methamphetamine or cocaine, and another 40% was using cannabis. On admission, as you see, a lot of patients had significant psychiatric symptoms, which is again not uncommon for this population. 64% had anxiety or panic disorder with a self-report scale at the clinical significance threshold. About 60% had major depression, 20% had ADHD or bipolar. So pretty, I think, kind of standard sample of the patients presenting to inpatient setting. Again, the study was done in the inpatient setting. So residential programs, one was the hospital. So when we looked at how well they did on the standard versus rapid, we were able to have 63% of patients who initiated the induction receive first dose in the rapid versus 35% in the standard, which really puts it at, when we do it in statistics and we tested, the odds ratio was way outside of one that was hypothesized, which is, again, 0.67 was the non-inferiority margin. We went way above that and way above one. So it was not only non-inferior, but it was actually superior at the very, very clear level. There was really no interaction with any demographic, so everybody did equally well. And again, there was no associated with fentanyl. So people have concerns. I had those concerns myself, whether we can do this procedure equally well with patients using fentanyl. But as you see here, equal number of patients completed the induction, whether they were fentanyl positive or negative. And this is the results of the prior outpatient study, again, 56 versus 32. So we got a little bit higher number, maybe not as high as we were hoping for. When you look at how long it took for patients to initiate extended release naltrexone, on average in the standard, it took about 14.5 days, and 50% of patients were anywhere between 12 and 17 days. It took only 7 days in the rapid, and again, 50% of patients were anywhere from 6 to 8 days. Some patients finished in as little as 4 days, and some patients delayed this for 12 days. When we look at the withdrawal severity, so this is cows, but the same results are for sows. As you see, the withdrawal was relatively low throughout the stay, throughout the treatment, around 6 of cows, which is really what you would had on average before you initiate buprenorphine. So basically the worst was day 1, and most of them afterwards were feeling very comfortable, and there was no difference between standard and rapid. So whether you taper buprenorphine, you go from 8, 4, 2, 3, or whether you start oral naltrexone, the withdrawal is comparable, right? Which is I think quite important. Craving was also similarly between the procedures. When we looked at why people left, again, a lot of people left. Most of them didn't give the reason. They said they just need to go. Usually they come up with some emergencies that they have to attend to on the outside. Often, it is the fact that they change their mind. Interestingly, about 20% of patients who decided to leave the protocol were patients who basically wanted to stay on buprenorphine, and we are very much encouraging patients to stay on buprenorphine if they feel well and don't want to proceed with induction onto naltrexone. And a very small number of people, but maybe a little bit more, 14% versus 5%, said that they don't want to stay because they are uncomfortable. So again, low rate of people who left because they are uncomfortable, although we don't know why people left, who didn't really say why they left. When we looked at, we were very interesting whether people, because they got high doses of adjunctive medications, whether there will be more falls, changes in mental status, medical complications, or psychiatric symptoms that are likely to be exacerbated by withdrawal. And we did not really see much of a difference. So statistically, it was not significant. So there was, in the standard, there was 1 person who had mental status change, 3 people had medical complications, and in the rapid, 4 people had falls, and 8 had medical complications. So it was a little bit higher, which is consistent with the fact that those patients got more higher doses. Overall, this was very low rates, but less than 5%, which is relatively low. So as a part of the implementation portion of this protocol, we've been developing procedures, the protocols, the various tools to help staff adopt this study. And we have created this website, EasyMOUD, where we have actually placed all those materials for public. So this is freely available, and we are hoping to include similar tools to help providers start methadone or buprenorphine, extended release buprenorphine in an easy way. We have also created this shared decision-making guide to, again, help the providers have a conversation with patients about which medication will work best for this patient. Many patients still don't know about naltrexone as an option for relapse prevention treatment. So it's important that patients fully understand what's the difference between those three medications. They are very different medications, and I think patients deserve to know and figure out which one works best for them. So we've created this guide. It's also available on this website. And here is just a list of the references looking at effectiveness of naltrexone, either versus placebo or versus buprenorphine, as well as the safety. So I will stop here, and I'll be happy to address any questions. Sorry if I went a little too fast. I just want to make sure that we cover everything, but I'm happy to take any questions at this point.
Thank you so much, Dr. Bisaga, for the wonderful presentation, and truly appreciate all the resources that you shared with our community here. I do see a question here from Megan. What was the eligibility for your patients? Were most of them on buprenorphine for a certain period of time? Did you find a correlation with that time frame and their success?
Right. So the patients who are eligible to be enrolled in the study were patients who were interested in initiating naltrexone, right? So people who came to the unit were approached by the research staff and were presented with the option to have naltrexone as one of the medications that they will leave the unit on, or buprenorphine. And patients who expressed interest in going on naltrexone were enrolled in the study. And again, the first day, everybody got buprenorphine. So some patients wanted to stay on buprenorphine, but patients wanted to go from buprenorphine to naltrexone. So, you know, before patients came, everybody was using illicit opioids. So we did not really enroll patients who were maintained and successful on buprenorphine. Well, those patients would probably not make to the unit in the first place, but we would not take patients away from the medication that was working for them.
Dr. Bisaga, thank you so much for your presentation today. It was excellent. I do have a question about follow-up. So it appears that you mainly focused on the initial injection and if they received the initial injection. Did you guys follow up after that at all to see how long they would remain on it? Because in clinical practice, that's actually my biggest issue is the second injection and the third injection. It's once we get over that barrier and get the first one, I noticed that patients seem to have a higher level of motivation with that first injection, but then they tend to drop off afterwards. Did this study look at any longer term adherence?
Oh, that's a good point. So one of the barriers is how to initiate naltrexone, and the second barrier is how to keep people on it. So this study was not focused on that second part. There is another study, CTN study right now that is ongoing that is focusing on long-term retention. But so patients who receive naltrexone in our study were referred to continue medication in the community. Sometimes it was the program that initiated them. Sometimes it was another program. Many patients left, and study did provide medications for people who wanted to stay. So we have a data of how many people took advantage of medication provided study. And it was, I think, about 30% of patients that made overall of those that started that continue for that 3 months injection. So again, not a large proportion. And it is important to know that, you know, like any treatment, you know, if you can provide, you know, full set of kind of treatment, right? Especially maybe for naltrexone more than buprenorphine, if you can provide a way to engage patient in care, right? To help them develop skills, how to navigate life without having to use, how to engage with the community, recovery community, how to stay connected and treat any co-occurring conditions. Those patients tend to do better. I think that's the case with both medications. When you actually, the studies that compare people who initiate buprenorphine versus extended-release naltrexone show that equal number of people end up staying for 6 months, about 50% of patients. So overall, for both medications, I would presume for methadone similarly, majority of patients don't really stay as long as we would like them to do. But, and I think that's clearly something that we can do, but we know very well that without medications, even fewer stay, or very few, and the risk obviously are insurmountable of what happens when you don't have medication on board. So in this study, we did not follow, but thanks for your question. This is a key, of course, key question,
There are two other questions from the community. I'll kind of combine them. One is, did you have any barriers with the cost? Because that is something that we struggle with, definitely in Texas. I'm assuming it's everywhere. So after the study is over, did you guys have difficulty finding those resources where the patients could go to continue the medicine? And then the second question is there any evidence pointing towards the risk of overdose with naltrexone versus the buprenorphine with the continuation of those medications?
Right. So the first question is, some states, the cost was not a problem because some states, Medicaid expansion states do provide medication to all the patients who are eligible. So there was not an issue. Other states, and I would imagine in Texas, that was the case, that you have to make a decision whether you want to fund buprenorphine or naltrexone because you have limited pool of money. And that, of course, makes buprenorphine being much more attractive, being at least sublingual buprenorphine being less expensive. Injectable buprenorphine, I would imagine, is similarly expensive as the injectable naltrexone. So again, many states don't have this challenge. Some sadly do. And again, in terms of the overdose risk after stopping medication, so there is, again, some of these references are included in this reference list at the presentation. There is overdose is a very rare event, and again, very difficult to show statistically convincing the increased risk. There are some large health records-based studies which show that the risk of overdose is slightly higher with naltrexone as compared to buprenorphine or methadone. So it is true that in a small portion of patients, that patients who are initiated treatment, they end up overdosing in some point down the road. That doesn't mean that people overdose immediately after, receiving injection or not receiving the next injection. They overdose at some point during the follow-up period. So there is a slightly higher risk, absolutely. But again, many people would argue with them, and there is a lot of methodological concerns about that. The bottom line is both medications, all three medications, are significantly more likely to decrease the risk. And it's important to find a medication. The best medication is the one that patient takes, right? So it's important to find medication that will be the most appealing for the patient and work with them to stay on this medication for longer. And again, most patients still choose to be treated without any medication. So, naltrexone will be a great option for the patient who does not want to take agonists daily or even injection, but would like some protection against relapse. So this is not really to replace other medication. This is just to complement what we are able to offer to our patients.
Hey, this is Alicia from Baylor. I had a question about, who you enrolled in your study, the participants, and sedative use disorders, co-occurring sedative use disorders, particularly with benzodiazepines, because I noticed the adjunct protocol relies a lot on using a benzodiazepine for symptom control. So if you could just comment on that and how that was handled.
Sure. Right. So we are using, all the medications that we can while patients are observing in patient setting to relieve the withdrawal. That includes clonazepam, which is our medication of choice, but other units use lorazepam, and that's average of let's say 2 to 4 milligrams per day, which keeps patients very, very comfortable. Now, this is not, of course, a concern during the inpatient stay because you can monitor patients, and patients, again, very much appreciate feeling comfortable. There were some patients who were coming to the study and were using higher doses of benzos on the street, and those patients might have required higher doses of medication during the inpatient stay. So that was the only difference, if I can think of. I don't know whether we have excluded a lot of people because they were at risk of impending withdrawal. I would imagine that if someone had impending alcohol withdrawal, or again, they were using, complicated withdrawals on the street right before admission because of the sedative hypnotics use, we might have excluded them, but I'm not sure if there were many, if any, like those. I'm not sure if that addresses your question. But after the receiving the naltrexone, some patients still kind of benefit from a few more days of lower descending doses of benzos and clonidine to kind of help alleviate some of the protracted withdrawal. So none of them are maintained on benzos, but they certainly may have troubles, sleeping and adjusting, and they may benefit from a few more days. So again, short prescriptions, which are very safe overall. But I do recognize that your question is about, this tradition of not using any additional medications for opioid detox, just using agonists, versus, let's say, alcohol detox, where we use huge doses of adjunctive medication, including benzos. So there's this discrepancy in the field of which medications are appropriate or not for which detox.
Hi, yeah, very, very interesting. I've always wondered, like, when I would want to perhaps do this myself. And so, I was just trying to think, well, from a clinical point of view, who would be the patients that would be motivated sufficiently to want to continue this? So right now, usually those patients that I see are like, health professionals or people like that, or, people that basically for their work or have been caught up with their board or things like that. But for others, I think I was thinking, I wonder if it would be helpful if somebody was going to spend, like, let's say 3 or 4 weeks in a rehabilitation facility. Theoretically, is it more helpful to do this, get that injection in sooner, try to, develop their awareness of how important it is to take their medication, and then perhaps even give them a second, injection before they leave, as opposed to, usually my impression is now what happens is they get detoxified, and the last thing they do on the day they leave when they're feeling good is to take that injection when it's more likely to be aversive. So I was wondering, do you have any thoughts about that?
No, I absolutely follow everything you said. And it is true that often the naltrexone is given right on the way out. So you don't have a chance for a patient to experience what it feels like to be on naltrexone while they're still in therapeutic environment. And I'm very much for patient be on medication and know what it feels like, feel the benefits of medication, taking away the cravings and just improving their mood and gradually improving their sleep. So they will be more likely to continue. And you're right. I would love them to receive the second injection, even if it's a few days earlier before they go home. So they have 2 injections. And I think that will be preferred rather than being like an afterthought, because you're right, they may not feel well after the injection for whatever reason, which is uncommon, but it's possible. And then they will say never again, right? Without having a chance to discuss this with you and psychoeducation around that.
Yeah. I think, well, at least when we did the waiver course, that, you tell, well, you might get the naltrexone flu or whatever. I always figured that's probably because you just gave the injection a little bit too soon. They hadn't quite adapted yet. But you know, if you actually squeezed in a couple before they left, or did it at the same time as you're doing in the first week, I think you'd be much less likely to have an adverse effect, at least in terms of, you know, subacute minor withdrawal kinds of symptoms. I mean, you might still, you know, there might still be some other, you know, mild side effects that people might have with the naltrexone, but anyway, that was just a thought that I had.
That's an excellent point, and I would absolutely agree with you. When it's given earlier, they may have a flu. When it's given 3 weeks later, they have really no adverse effects. And so you may need to know about this and discuss with the patient. But I still feel it's better for the patient to be longer on the medication in the therapeutic setting to continue with the medication.
Yeah, you know, you don't have 28-day programs so much anymore. A lot of times people it's 2 weeks, it's, you know, so you're really sort of cutting it close, if they have an opiate use problem.
True, absolutely.
Thank you so much, Dr. Bisaga. This has been a wonderful discussion. In the interest of time, we will move on to our next part of the program, but I do encourage everyone to keep posting your questions in the chat so we can continue this discussion. Thank you so much, Cato, for sharing the announcements. To claim a CME credit, you must text by midnight tonight. So please text attend 1009-5147 to the number you see on screen to receive your CME credit. Next slide, please. Do you have a difficult case that you or your team has encountered? CSTAT offers you the opportunity to present any challenge your organization is encountering and receive feedback from our hub of experts and broader learning community. There is no need to prepare a formal presentation. We will provide you a case form to assist with your case presentation. Please email us at cstat@utisca.edu. Next slide. Please join us for our next session, which will be on Tuesday, January 16th. We will be talking about the use of psychedelics in alcohol use disorder. Next slide, please. The Texas Symposium is happening in Austin on Feb 29th and March 1st. It is now open for registration. The registration is free and you do get CME credits. So please visit us at texas.org and register. And with that, we will move on to our case. And just before the case presentation, I do want to remind you all that we will not be sharing any PHI during the case presentation or the case discussion. And that means no, including names, addresses, phone numbers, dates, pictures, or any identifying information. Kenzie will be presenting our case today, and she will be using a pseudonym to help discuss the case. Kenzie, you can take it away whenever you're ready.
All right, just give me a moment to share my screen. Can everybody see my presentation?
Yes.
Okay, great. Yes, thanks for having me again, and I'll be presenting the clinical case. Just some quick background on this. This is a case that we created to exemplify common patient experiences that we saw in CTN97 with rapid naltrexone inductions. So Jerry is a pseudonym and there's no PHI included. So Jerry, in this case, has reported to our detox unit seeking help for his drug use. His current drug use is assessed, and we learn he's using 3 bags of fentanyl nasally every day, has 2 to 3 beers a week, cannabis smoked daily, and smokes meth about 2 to 3 times a month. As for his opioid treatment history, previously he'd been a heroin user for about 20 years. He'd gone into a 5-year period of abstinence after that, and then relapsed onto fentanyl 2 years ago. So he's been on fentanyl for 2 years. He's tried multiple inpatient treatment facilities to treat his opioid use disorder, even methadone maintenance programs a couple times, but while he was on methadone, he wasn't feeling very well, even at high doses. So when he reports to our detox unit, a physician sits down with Jerry, to discuss medication options, and he'd never heard of Vivitrol before, so he's interested in trying something new and not agonist maintenance. So now that we know he's interested in Vivitrol, we're going to assess him for withdrawal and start our buprenorphine doses. At arrival, he presents with sufficient withdrawal symptoms to start that 2 milligram buprenorphine dose. We observe him for an hour, and then after that, we determine he's not having any kind of adverse reaction to the buprenorphine, so we can give him a second dose of 2 milligrams. However, after that second dose, we notice that his clinical opioid withdrawal scale score has jumped up to 13 from 6, and he's reported vomiting to some of the clinic staff. So this proceeds to our first question of the case study. How would you proceed at this point? Our options are wait for a few hours and repeat buprenorphine dosing 2 milligrams once the patient is comfortable. That's A. B is use adjunctive medications to make him comfortable and then repeat that 2 milligram dose once he is comfortable. And C, give 16 milligrams buprenorphine to override the withdrawal at that time. So if we can start the poll, perfect. Everyone can indicate their answer on the poll, A, B, or C, and I'll just give a few minutes for people to put that in.
We should be basing this based on what we learned previously.
Yes,
or that we
that's
think
correct.
we perhaps maybe have learned.
Yes, this is within kind of that rapid naltrexone induction protocol Adam
Okey-doke.
presented on. Thank you for asking. All right, so I'm seeing overwhelmingly choice B is our preferred answer. So good job, folks. I agree. We preferred in our study to use adjunctive medications to soothe any kind of withdrawal symptoms and then restart buprenorphine when comfortable. And really the key is to start adjunctive medications before or during these buprenorphine doses so you can get ahead of any new withdrawal symptoms and kind of mitigate that increase that could happen through treatment. So here I've listed some common adjunctive medications we used through the study that can address symptoms like general withdrawal. That was your clonidine. Anxiety and restlessness is when we would give clonazepam, but we also treated muscle and joint pain, nausea, GI issues, sleep, nicotine withdrawal, and dizziness or lightheadedness with a lot of hydration for that one. So the keys here are really to make sure that adjunctive medications are at sufficient doses to keep the patient comfortable and mildly sedated. Often we heard that the best experiences were when patients were able to sleep through their withdrawal. They'd wake up, be able to get their low-dose naltrexone and their naltrexone injection and go home pretty happy and having a positive experience with their detox process. There's a minimal concern for over-medication as long as you're monitoring, again, for hydration and falls. We want to make sure that if patients are on clonazepam, that they're monitored during bathroom breaks and they're not really getting up and moving around too much, just mostly staying in bed and resting. And yeah, great job, everyone. So I'll move to the next portion. So now that he's tolerated his buprenorphine doses, we get him through a washout day, still on his adjunctive medications, and we're moving into low-dose naltrexone. So his first day, he tolerates his doses well. And then once we move into the second day, his 3.0 milligram naltrexone dose precipitates mild withdrawal. However, Jerry's kind of tough and he wants to proceed on with his low-dose naltrexone dosing so that he can get home before the weekend. And he's antsy to leave. So in this case, how would you proceed? A is wait and give 3 milligrams and 6 milligrams the next day so that you can give Vivitrol on Saturday. B is increase adjunctive meds and give 6 milligrams to give Vivitrol on Friday morning if the 6 milligrams is tolerated. And C, wait and give 6 milligrams on Friday, and if tolerated, follow up with Vivitrol that same day. And then we'll do a poll again. Perfect. Just give a moment for folks to answer. Okay, I'm seeing mostly B for our answer again, and this is a bit of a trickier question than the previous one. So I will go ahead and hand it to Adam to explain our reasoning here.
Right, so it must have been, might have been a little bit too tricky. So the issue is that once you start seeing some reaction of the system to naltrexone, if you're gonna give the next dose, you're probably gonna precipitate with more of a withdrawal. So it's really better to give a long time for the system to kind of reset itself. And this 3 milligrams still will keep working for many hours. So we have found is that it's better to skip the next dose and restart the process the next day rather than to push through, although pushing through may also be acceptable to some people. Either case, B and C, they would get injection on the next day, which is preferred. And I think we have, I don't remember if we had many patients actually who wanted to speed it up to be in any serious withdrawal. Again, the first few doses, 1 day of low dose, 2 days of low dose really washes out any remaining physical dependence and is usually okay. So I think both are fine, but I want to make sure that, give a little naltrexone and they start getting sick, you probably want to hold off before you give next. You may hold off like for the next, for the rest of the day. Yeah. I don't know if anybody, go ahead, Casey.
Yeah, I was also just going to add that 3 milligrams is often when we'd see folks have that kind of increase in withdrawal symptoms during the low-dose naltrexone titration. So after that dose, if you gave a moment and went to the next highest dose, it was rare that, they would have more of an adverse reaction, but it obviously depends on the patient case and making sure that they're having those adjunctive meds continue through that process. And then another issue is when patients are looking into staying in admission through a weekend. That caused a lot of transition issues with care where in handoffs, patients would see that their care was getting delayed and decide to leave and abandon treatment right before getting that Vivitrol injection. So trying to get it in earlier was always better for the folks who needed it. All right, and then after Jerry completes his low-dose naltrexone doses, he got his 6 milligrams and his Vivitrol very well on Friday. He was observed for 2 hours after that Vivitrol injection to make sure he doesn't have any immediate adverse reactions, but he's looking good to go. So we sent him home, and in his next follow-up, he complained of severe insomnia together with mild anxiety and a brief episode of depressed mood. And it's important to educate him at that point that this is frequently a side effect of Vivitrol, but it should be brief, and then make sure that if there's any persisting issues like these, that they're treated with adjunctive medications. And then in his 3-week follow-up, Jerry felt normal, no withdrawal or craving, and reported it as his best ever detox experience. So yeah, thanks everyone.
Thank you so much, Kenzie. And yeah, I will open up the floor for any further questions, or if anybody has any idea of if they would have done something differently.
Well, so the insomnia and anxiety, it seems that's probably his system is still adjusting to being off of the opiates, right? So, but it sounds like a tolerable level. What were you prescribing him for his insomnia and anxiety and stuff over that 2 to 3 week period?
Right. So it depends on the patient. I think most patients get continued on clonidine, which they find very useful. Get something for sleep, trazodone. Most of the time, quetiapine if they have severe insomnia. Some patients are fine with getting, a few days of zolpidem. If someone has a very significant anxiety, like they're really panicking, a few days of clonazepam may help. The important is that it's very short. Those discomfort is very short, and it only happens after the first injection. And and the patient know to expect it and know that we can manage that and know that this is, limited, and they really appreciate being kind of informed and being participating in this process, and of course checking with them every day. I think this protracted withdrawal is not unlike what we see with fentanyl patients switching to buprenorphine. As you know, often the buprenorphine doesn't cover all the withdrawal, and patients still don't feel well transitioning, not even mentioning people transitioning from high methadone dose onto buprenorphine, where this continues for even longer. So this transitioning, the protracted withdrawal, I think it's important that patients know to expect and have some tools to manage that.
And there's a question in chat about when do you stop buprenorphine?
Right, so they only get buprenorphine for 1 day in this protocol. Right. So in this protocol has minimal buprenorphine just to step down. And some people even saying that you may not even need buprenorphine. We have done the study when it looks like no buprenorphine didn't really make that much difference. But I think people do expect something for withdrawal, even mentally, knowing that you're going to get bup. Patients like, wow, that's good. If you tell them you're going to get only clonidine, unfortunately, patients expect the worst. So
And then
I think Tanya.
Another question, Tanya?
Yeah, I'm curious. So we use Vivitrol here at Texas Clinic. We do a lot of med AUD. So we use Vivitrol for alcohol quite a bit. My question is, I noticed on there that he drinks. Was the interaction with the alcohol and the Vivitrol, was that discussed, that the Vivitrol, that there may be some changes in his ability to drink, feel it? I mean, how was the alcohol addressed with the Vivitrol, since we use Vivitrol to treat alcoholism?
Absolutely, it's an excellent point. Vivitrol looks like have a anti-craving effects through a variety of substances, right? Certainly it's FDA approved for alcohol, but it's been found helpful for stimulants and for tobacco. So there's certainly for craving for food. So clearly we are telling patients to keep track of it. And some patients find the relief, some patients don't find a difference. Luckily it's not antabuse, so we don't have to warn them about possible negative interaction. But it certainly could have benefits for other substances. And it's good that patients know that. Unlike buprenorphine, right, or methadone, we always have to warn them about, consuming large doses of alcohol with the medication may be actually problematic. So that may be a good thing to know for some patients when they're choosing which medication works best for them.
I was going to ask how often you ran into issues with the clonidine. So one of the treatment programs I work with serves a lot of relatively young, healthy women that start out with blood pressures in the 90/60, 90/50. And we typically do use clonidine to help with bup induction coming off of fentanyl, but have had, a not insignificant number of patients that have had problems tolerating the clonidine because of the blood pressure effect. And I just know what you saw in your work here and what else you did for that.
Right. So we see the same. Obviously, young women, especially small frame, tend to get hypotensive effect even with 0.1. So definitely in those people, we do give 0.1 rather than 0.2, which we give in everybody else. Obviously, kind of aggressive hydration is the way to go. We don't want to give IV fluid. So we kind of really stay on top of them and encourage them to drink Gatorade all day long, at least 6 to 8 cups. So basically everybody has a pitcher and have to drink and have to eat salt, even though they may not have appetite in withdrawal, but we encourage them to eat saltines and drink Gatorade. But some people cannot tolerate. You're absolutely right. And so lofexidine would have been a better choice. Unfortunately, it's still prohibitively expensive. I'm hoping that this will go off patent soon. Alofexidine is widely used in other countries, in UK, and better tolerated. I don't know about other alpha-2 agonists, but yeah, that's a downside for those people. And again, clonazepam may be a better alternative for them.
And just a follow-up to that was, were the falls that you did see, did you feel like they were more related to the clonidine or the clonazepam or something different?
I would guess, clonidine, but clonidine. But I would, if someone is sedated, we do encourage them to stay in bed. And again, patients like to be sedated. Patients like to sleep in detox, right? The best detox is when you sleep through 5 days and you don't remember what happened. This is not the time to be engaged in a kind of very intense group experience. This is the time the patients, we want them to stay, not to leave. And we know that if they're not sedated, they may be very anxious to go. So you have to then weigh safety. Obviously you may need one, kind of closer nursing monitoring, which is a challenge. But patients do like to be comfortable. That there's no question about that.
Thank you so much, Dr. Bisaga and Kenzie. This has been a wonderful discussion. In the interest of time, I will request Dr. Kovalchuk to summarize the session for us today.
So in summary, today's session has been about rapid induction onto naltrexone from patients that have OUD using very low doses of naltrexone after 1 day of low dose bupe and a day washout, and lots of adjuncts to keep people really comfortable throughout. And saw good success with that compared to standard induction onto naltrexone, which can be up to 2 weeks. This really averaged up to about 7 days with similar rates of complications or adverse events, and was overall tolerated similarly with similar levels of withdrawal.
Thank you so much. And thank you all again for joining today's ECHO. We understand it's the holiday season and we are still grateful that you are able to make some time to join us. As a quick reminder, please text the activity code 1009-5147 to 844-502-1338 by midnight tonight to earn your CME credits. We also request you to complete the post-session survey using the link in the chat. The survey link will be open for 1 week. If you would like to present a case, please email cstat@utisca.edu. We look forward to seeing you at our next session, which will be on Tuesday, January 19th. As a reminder, our other echoes for the rest of December have been canceled in view of the holidays. So our next session, we will resume in January, starting with the harm reduction echo on Jan 4th. Happy holidays. Have a wonderful rest of the day and year. Be safe. Take care. Bye-bye.